This is going to be a 15-minute lecture about interventional ultrasound of the hepatobiliary system, which covers the following topics: PTC, PTBD, liver abscess drainage, liver biopsy, percutaneous cholecystostomy. The image on the left basically sums it up. But first we'll do a brief description of the above-mentioned procedures and their uses. PTC is percutaneous transhepatic cholangiogram, wherein we inject contrast into the intrahepatic ducts. This is done to map out the biliary tree and define exactly where the site of biliary obstruction is. This is an example of a PTC in a patient with a distal common bile duct stricture. But I have not been doing this much recently because of the availability of the MRCP, which basically does the same thing. However, PTC does provide the option to do a PTBD immediately after. Putting in a PTBD is easily done after PTC using the Selinger technique to insert a drainage tube through the intrahepatic ducts, with the purpose to drain biliary obstruction of different causes. In this example, a PTBD tube was inserted in the right intrahepatic duct to palliate obstruction from a pancreatic head tumor. PTBD can be done through the left or through the right intrahepatic ducts depending on where the obstruction is. Next is percutaneous cholecystostomy. It is an option that we could do for inoperable or unstable cases of gallbladder hydrops. We usually prefer to do this transhepatically to lessen the chances of peritubal leakage into the peritoneal cavity. This is actually easy to do because with ultrasound guidance, a hydrophic gallbladder is very hard to miss. Another thing that we could easily do with ultrasound guidance is aspiration or drain placement in liver abscesses or cysts. Especially in amoebic liver abscesses like this, which are big and easy to hit with a needle. Ultrasound guidance will also help you in doing core needle biopsies of liver tumors. So how do we start learning how to do these procedures? The techniques we employ for these procedures are similar in that all we need to do is to successfully guide the needle into the structure in question with the aid of ultrasound. And from there, we employ the Selinger technique to place the catheter into what we want to drain. Only the needles and the catheters differ. All of them can be done under local anesthesia with or without sedation. What materials do we need to prepare for these procedures? Aside from the ultrasound machine and the local anesthetic, we need the following: a long spinal needle, big enough to fit the guide wire within, dilators, and a drainage catheter. For biliary drainage procedures, there are commercially available catheter and dilator sets which are specifically tailored for biliary drainage. They have longer needles, catheters, and guide wires, which would make the procedure a lot easier. So basically, as I've said earlier, we only need to hit the intrahepatic ducts to be able to do a PTC or PTBD with the needle. And there are two ways to insert the needle under ultrasound guidance: the in-plane versus the out-of-plane technique, or what we call parallel versus perpendicular. This describes the relationship of the needle to the ultrasound probe. This is the parallel insertion technique. Note that the needle is parallel to the long axis of the ultrasound scanning plane. Also seen at the diagram on the top. There are various angles by which the needle can be inserted using the in-plane view. In the in-plane view, a longitudinal section of the needle is seen on the ultrasound. In contrast, this is the out-of-plane technique, wherein the needle is inserted perpendicular to the ultrasound scanning plane. This is seen in the diagram at the bottom. There are also various angles that the ultrasound probe and needle may be angled in the out-of-plane technique to guide your needle and to reach your target. Take note that in the out-of-plane technique, only a cross-sectional view of the needle is seen, like this tiny dot over here. These two techniques, the in-plane and the out-of-plane techniques of needle insertion, are not exclusive. A lot of times during procedures, one will have to switch between these two techniques for one to be able to see where the needle is. There are also two ways of holding the needle during the interventional procedure. We have the free hand, and the other one uses a needle guidance system. We usually prefer the freehand technique, as this is more flexible in that we can go parallel or perpendicular at any time. Or one can elect to use the needle guidance system, wherein you're basically assured that the needle is within your scanning plane at all times, making it a lot easier for one to see where the needle is going to. So the most common problem during interventional ultrasound procedures is not being able to see where the needle is. In the in-plane approach, you have to make sure that the trajectory of the needle is perfectly in line with the transducer, with the ultrasound scanning plane, for you to be able to see it. This is this is seen on the diagram on the left. When you keep the needle within the scanning plane, you would be able to see the entire length of the needle as it goes through the liver. Compare that to the diagram on the right. When the tip of the needle goes out of the scanning plane, you will not be able to see it, and you won't be able to hit the structure you have focused on. This is when this needle guidance system would help somewhat, because it keeps the needle in the correct plane, in the correct ultrasound scanning plane. Other tips to be able to see where the needle is while it's traversing the liver is number one, uh, moving or jiggling the needle. This jiggling motion of the needle makes it a lot more visible compared to the stationary structures you are traversing. Number two, often looking at the relationship of your needle to your probe will help you in determining the needle's location better. And looking at just the ultrasound monitor is sometimes disorienting. Another thing to take note is needle tip shaft echogenicity. Of course, large gauge needles are more easily seen, but there are commercially available echogenic needle shafts. These needles reflect echoes better, but we usually just use a blade to score or scratch the shaft to see the needle better. After hitting the intrahepatic duct or the abscess cavity that we want to drain, we just employ the usual Seldinger technique to insert the catheter. After needle insertion, we place a guide wire in, and then we place a small incision, no? And then use dilators sequentially in a twisting motion, before finally inserting the catheter. So going back to the specific procedures, when when doing a PTC, usually a small gauge spinal needle is adequate. And before inserting the needle, you must measure the depth of the intended bile duct to see if your needle is long enough. Take note also that doing a PTC is not always easily done when the bile ducts are of normal caliber, as they are not visible on ultrasound. Needle insertion in between the intercostal spaces is okay for the right hepatic ducts, as long as there is a clear path and the ribs are not blocking your transducer view. This is the percutaneous transhepatic cholangiogram I showed you earlier with the distal common bile duct stricture. In doing PTBDs, I found that using a pigtail catheter to be ideal. Pigtail catheters like this. But then again, during training in PGH, we just used regular French 8 to French 12 feeding tubes, which are very cheap, very cheap. In the picture, the dilated bile duct is seen and the needle is inserted. Here we employ the in-plane approach of needle insertion with the free hand technique of holding the needle. As you can see on the ultrasound image on the left, the shaft and the tip of the needle is very visible. Bile can be seen to flow out in obstructed cases. And then we use a mosquito to clip the needle flush to the skin so that it doesn't move or get displaced. A guide wire is then inserted, and then subsequently dilators up to one size bigger than the drainage tube you are planning to insert. And then finally, we insert the drainage tube. This is actually just the common 50 peso feeding tube I was telling you about earlier. During our fellowship days, we actually reused our dilators and guide wires plus used this feeding tube. As this is very economical for our patients. Yeah, ultrasound could also be used in guiding ultrasound in core needle biopsies of the liver. The usual long core needle is used, like the one here in this picture, but I think this is too short. A longer one uh, is the one that we usually use. We position the tip of the needle right before the mass and not inside the mass to lessen chances of injury to deeper structures before firing. As exemplified by this diagram. Drainage of hepatic abscesses or cysts. Doing drainage of large abscesses or cysts are fairly easy to do compared to PTBD. Amoebic liver abscesses like this are pretty hard to miss on ultrasound. And then a large bore pigtail catheter, or maybe placed, or just simple aspiration may be done. That concludes my lecture on interventional hepatobiliary 3 ultrasound.